Hi there. Now, this video I'm going to look at the overall purpose of the consultation and hopefully follow up with another video looking at how you can phrase questions to hopefully make this as efficient as possible. If I think back to how I consulted when I was a medical student first seeing patients, I'm pretty sure I just asked all of the questions I could think of, and towards the end I'd start thinking about what the diagnosis might be, and afterwards really sort of finalise my thoughts, and then definitely not till after I'd finished with the patient would I start thinking about what sort of treatment plan I might have. Now, in a hospital setting, it is possible to continue that kind of consultation model, but just get more and more efficient at it. So, and you can get away with that because symptoms are often quite pronounced. There are no negotiation needed with patients because they're there for you to do whatever you think is best. Their idea is generally that they're ill, and the concern is that they're really ill, and their expectation is that you'll do something about it. Tests may well come back within an hour or so. So you can definitely get away with this sort of tighter, more narrow data gathering. I'm sure there's plenty of situations where it's more complicated, but you can get away with that kind of model. Obviously, within general practice, a wider range of data gathering and considerations are needed. And multiple factors for this. Symptoms are often mild and a bit mixed, and it's not always obvious why the patient's actually attending. So one of the purposes for the consultation as early as possible is to really be sure you know why this person is attending today. While we're data gathering for the diagnosis, we also need to be thinking about what sort of examination we're likely to propose, what sort of tests we're likely to suggest, and what sort of treatment options are we likely to hand over. And the other stage of data gathering is the patient's illness side, their unique perspective, their circumstances, so that we can then match those together with our the plan we've been thinking of, and try and work out before we start suggesting the plan and the tests, so we can match them all together so it's acceptable and accepted by the patient. So in terms of patient's perspective, I'm thinking about the ICE questions. So ideas would be, what sort of condition did the patient think they might have, and also what might have led to that. So not just a diagnosis, but what might have led to them getting ill. Their concerns would be, what would be the worst illness they were thinking of that they might have, or what's the worst impact of the illness that they might have. The expectations would be, what sort of thoughts did they have on tests that might need to be done, or treatments that might be offered. And there are often other non-medical things, like maybe they're expecting a sick note, for example. So we need to be getting all that data together so that we can then match it to our plan that we were thinking of. As doctors improve the way they consult, so generally you start with the data gathering for the diagnosis, then you'd be including the patient perspective, data gathering, and probably as you get better at the disease, understanding your ideas on tests and treatments are likely to be coming into your head at the same time as the diagnosis are coming to your head. And then the final stage in this sort of GP development would be to be able to work out a diagnosis during data gathering, find out the patient's perspective, think about what sort of tests and treatments are likely to be proposed, and then be matching them together so you can probe towards the end of the data gathering to work out how that might all fit together, so that when you hand over the management plan, it's more likely first time to be one that the patient accepts. It seems like a lot to do, but with efficient questioning, nice open questions, knowing why you're asking the question, it can be done. And if you compare that to a doctor-dominated consultation where lots of closed questions are asked to try and guess at the symptoms, which takes a lot longer than open questions, and then dictating to the patient your management plan, which may have absolutely no relation at all to what the patient wanted, and which would lead to the end of the consultation going round and round in circles trying to work out what's going to a middle ground, which will end up with a long consultation. So let's think of an example. So let's say someone comes into you with a 60-year-old guy with knee pain. You do some data gathering, ask some questions. It's pretty clear to you that the patient has osteoarthritis of the knee. So you start thinking about what sort of plan you're going to put in place. So you think, right, I'm going to organise an X-ray. I'm going to tell him I'm pretty sure it's osteoarthritis. I'm going to prescribe him some naproxen, and I'm going to refer to physiotherapy and suggest that if it's not getting better in 3 or 4 months, we refer him on to orthopaedics to think about an operation. Sounds like a reasonable plan. However, you've done an ideas question and found that actually he's really worried about rheumatoid arthritis, and the expectation is that he's going to have a blood test to rule that out. And it turns out that that was the purpose of the consultation. That was his sole purpose. So he didn't want anything else. That was what he wanted. He always gets reflux with naproxen and ibuprofen, so he's going to say no to that. He's only tried paracetamol now and again. He's not really sure whether that works or not, so you could suggest him using it regularly for a few days when he gets flare-ups. He doesn't want an X-ray because he had an X-ray a year ago and it didn't make any difference to what he was doing. He doesn't want physiotherapy, but you find out that's because he had one session a year ago and then did exercise for a week and then stopped them. And you suggest to him how actually physiotherapy doesn't work by the one appointment, but because you then do exercises for weeks or months and then have follow-ups and gradually change the regime. So he is actually now thinking about that. He definitely does not want any operation in the next year or so because he has got lots of work commitments. So So if you had just handed over your plan, the patient would have resisted it. They wouldn't have been happy with it at all. That's nothing to do with what they wanted. They would have said no to the ibuprofen, and you might not have known why. And they don't want anything else, and they don't want the physiotherapy or the X-ray. And you're thinking, well, why on earth did you come here? And the consultation is going to go round and round in circles, and it can be very hard if you haven't found this information out first, and then you come out with what you think is the right plan for the patient, and they completely resist it. Then it's actually quite stressful for both you and the patient to try and work out what to do next. The consultation will be long, and you'll probably feel pretty unsatisfied by the end of it. However, if you found out that information beforehand and able to merge that in together for your management plan, even if it wasn't perfect, it will be a pretty quick management discussion because you've been pretty accurate with your proposals, and it will be easier to then find a middle ground. So, what else was I going to say? So just one last thing to say, really. When data gathering, you don't need to ask all of the questions because you don't need to know everything. You need to know enough to make an accurate diagnosis as best you can. You need to know about the patient's perspective to then be able to match all this together and produce this patient-centered plan. So when you are data gathering, have a think. Do I actually know why this patient has made this appointment? And do I know whether they will approve of my plan? So we've got lots of things you can think about, but maybe just have a think about that when you're next consulting, about whether or not you really know. Has it really been clarified this is why they're attending? And when you're thinking about things to suggest, have a think about how could I check that those are things that the patient might want to do. Okay, good luck. Have fun.